My name is Jerry Clark, and I'm a resource and advocacy manager at the nonprofit TAC, Treatment Advocacy Center. This Advocacy Navigator training series is designed for care partners, family, and friends who care for someone with a severe mental illness, such as schizophrenia or bipolar disorder. That's what TAC means by the term SMI. This edition of Advocacy Navigator covers access to treatment, will cover voluntary and involuntary access to care. If SMI has newly entered your life, please be patient with yourself because there is a lot to learn. We hope this training series and other resources within our Joan C. Scott Community Resource Center are useful to you. This training series offers an overview of complex topics. We offer individualized support through our helpline if you need additional assistance. Many of the slides include QR codes, so you can easily look for additional information. Where to start always begins with ourselves. Whether you are watching this as a person caring for someone with SMI or as a person with SMI, you will need to adjust expectations and practice patience. Finding consistent ways to practice self care will be critical because SMI is a lifelong trek, not a sprint. TAC's FAQ article is a good place to look for additional tips related to questions you may not even know that you have. Thank you for your willingness to wonder and to learn. Getting into treatment is a bigger hurdle than people outside the SMI world could ever imagine. The basic truth is that the SMI treatment system has two entryways. One is voluntary and the other is involuntary. The voluntary path is always preferred, but requires that a person be motivated to seek and adhere to treatment. The person with SMI must be functional enough to make and maintain appointments, and they must be able to find and pay for treatment. Provider shortages and insurance barriers get in the way. Still, the biggest barrier to voluntary care is the illness itself. Symptoms that block insight are common and often persist, even when treatment is otherwise effective. When a person absolutely believes that they are not sick and don't need help, involuntary treatment may be the only way to save a life. If SMI symptoms are new and a diagnosis or initial treatment is not yet established, a place to start looking for treatment is the website findtreatment.gov, which is provided by the Federal Substance Abuse and Mental Health Services Administration, SAMHSA. There's a Spanish language and culturally relevant alternative called encuentraapoyo.gov. These websites enable a search by county and state. Keep in mind that most of the listed services require voluntary participation. Anosognosia is the name for the neurological symptom that prevents a person from recognizing that they have an illness. Anosognosia is the most common reason people with SMI may not seek or adhere to treatment. TAC's website includes an article with more information and a pronunciation guide. Learning whether anosognosia could be a factor in someone's illness can shift everyone's approach, but it's not always discussed in care planning. Families across the country are playing a role in making this word more familiar. If you are a care partner, you might ask a provider, could anosognosia be the reason my loved one with SMI doesn't stay in treatment? If so, what could motivate treatment adherence? All care partners need to adjust communication strategies if anosognosia is part of the illness. Just as you cannot talk someone out of a fixed belief rooted in a delusion, you cannot talk someone out of experiencing anosognosia. Use active listening, empathy, and collaboration to build trust. Over time, it may become possible for a person with anosognosia to see that SMI treatment improves their quality of life, even if they never believe that they are ill. Motivational interviewing is the term for this overall approach. Tax article with communication tips is a place for general guidance and includes places to go for training from experts. Here are a few key points. Because trust is key to motivational interviewing, it's helpful to ask permission before you share your ideas. Avoid statements that the person might be wrong or crazy. Try asking questions instead of telling someone what you think they should do. Keep in mind that a person with a brain based illness may need time for rest and processing. Honor their stamina and approach a conversation from a place of humble curiosity, compassion, and kindness. Treatment is a broad term, so it's important to consider what types of care a person might need. Many communities lack a full range of inpatient and outpatient options, which are collectively called a continuum of care. Here are some best practice outpatient options to consider. ACT or ACT refers to assertive community treatment, which is a team based approach for delivering services when and where a person needs them. ACT programs are generally voluntary, and even though outreach is a component, these services require a person to function with relative independence. AOT refers to assisted outpatient treatment, which is also team based, but it's involuntary. The client and the treatment team are responsible to follow a court ordered treatment plan. In some communities, AOT is implemented by ACT teams, which can be confusing. What's key to know is that ACT by itself is voluntary, while AOT is involuntary. Some states give their court ordered programs different names, such as mandatory outpatient treatment or MOT. Another intensive outpatient program option in some areas is called partial hospitalization, in which a person spends the bulk of a typical workday in the hospital but does not stay overnight. Evidence based psychological therapies for SMI include cognitive behavioral therapy for psychosis, called CBTP, dialectical behavioral therapy, or DBT, and MI, motivational interviewing, which has already been mentioned as a strategy when there's anosognosia. These therapies often complement medication therapy, which rarely enables stability all on its own. A hub for evidence based care in some communities is the CCBHC. That stands for Certified Community Behavioral Health Center. To be certified, these centers must offer many of the services that the SMI population needs, including combined care if someone has a severe mental illness with a co occurring substance use disorder. Family support is part of the model, which supports case management and crisis planning. The QR code on this slide takes you to a state by state listing of CCBHCs. When access to treatment through the voluntary door is impossible, you may need to know how to get through the involuntary door. Every state requires a legal process for someone to be hospitalized or compelled into outpatient treatment against their objection. These are civil court processes, not criminal. Sometimes confusing words like detention are used, but a person under commitment is not there because of a criminal charge. A person under a commitment order has met state criteria for an intervention that is intended to save their life. Ideally, that treatment will also start them on a path to recovery. The key that unlocks the involuntary door is language within state laws. In an article called Seeking Commitment, TAC provides guidance about how to unpack what state law says and link it to symptoms and behaviors to advocate for involuntary treatment. Included is a sample letter of advocacy. TAC's interactive map can help you look up your state to research the relevant treatment laws. On each state page, you'll find entries for 3 stages of involuntary treatment: emergency evaluation, inpatient commitment, and outpatient commitment. Here are the basics. An emergency evaluation is a short term process that involves an initial hold. Usually, law enforcement or mobile crisis responders transport someone who meets criteria to an inpatient facility to evaluate their condition. They might stay for hours, days, or about a week, depending on state law. If providers in the facility believe inpatient commitment criteria are met, they might file a petition with the local civil court, asking a judge to uphold an order for the person to be hospitalized for up to a certain amount of time. That time frame also depends on state law. An outpatient commitment, usually called AOT, is most often ordered by a civil court judge upon discharge from a hospital. All but 2 states, Massachusetts and Connecticut, have laws that allow for outpatient commitment, but not all states use their laws. Outpatient commitment works only when there's a program ready to serve the person in need. Whether a person enters the treatment system through the voluntary or the involuntary door, insurance barriers can get in the way. The United States has a parity law intended to ensure that mental health care is covered on par with physical health, but there are loopholes and there's not enough oversight or accountability. Tax article provides guidance about how to figure out who oversees your medical plan and what to do if you need to file an appeal or a complaint. Although it can feel cumbersome, appealing can be worth your time, especially if you understand your rights and ask for all the necessary documentation. I hope the information in this training is useful to you and that you will continue to learn by accessing the resources on TAC's website. Here's a reminder that you can receive individualized assistance by reaching out through our helpline. Thank you for listening and learning, and I wish you well as you navigate the complex SMI system. Please keep in mind that you are doing the best you can with what you know and the possibilities available. You are not alone.